Hello and a very warm welcome to everybody joining us today, whatever time of day it is for you and wherever you're joining us from, and whether you're joining us in real time or afterwards on YouTube. So to briefly introduce myself, I'm Bryony Dean Franklin and I'm Director of the NIHR North West London Patient Safety Research Collaboration. And that's a research centre funded by the National Institute of Health and Care Research to carry out research into patient safety. We're doing research in 4 themes. The first is around influencing patients and healthcare workers' behaviour to optimise patient safety. The second is around developing and testing technologies to enhance medication safety. The third is around how we can make better use of data, and in particular big data sets, to address patient safety challenges. And the fourth is around looking at patient safety in new service delivery models, such as virtual care. So there's 6 such research collaborations across England. We're all connected via a network, and I'm delighted that some of our speakers today are from these other collaborations. So World Patient Safety Day, which falls on the 17th of September every year, is an annual global event hosted by the World Health Organization. It started in year 2019, and there's been a different theme every year. This year's theme is Engaging Patients for Patient Safety, highlighting the importance of involving patients and families in all that we do. And I'm particularly delighted that this is the theme of this year's World Patient Safety Day, because it's a really important area and one that we're passionate about within our research collaboration as well. And so given the theme of this year's event, I'm also delighted that our event this year has been co-designed with patient representatives from the NIHR North West London Patient Safety Research Collaboration and from Imperial College Healthcare NHS Trust here in West London. So thank you to you all. Before introducing our speakers and a bit more about today, I just want to highlight a few practicalities for you. We are going to be having a panel discussion a little later on, and there'll be the opportunity to ask questions of our panel. During that session, the Q&A function will go live within Teams, so that will be enabled just during that panel discussion, and that Q&A function can be found towards the top right-hand corner of your screen. Those questions that focus on the topic of discussion will be passed on to the panel, and we may or may not have time to address all of those, but please do put your questions in the chat. You'll also be able to vote for existing questions to move them up and down the priority list. We also have subtitles available in English and in other languages. These can be found again in the top right-hand corner of your screen if you select the 3 dots where it says more, and then there's some options under there for languages which will allow you to access those. We will have a comfort break at around 11:40 a.m. and we're also delighted that we've got an illustrator working with us this morning who will be illustrating the content of our session on 2 canvases, the first of which will be displayed during the 5-minute comfort break later on. So please do look out for those. So back to the important topic of today. So our aim here is to really elevate the voice of patients and families in patient safety in all that we do in healthcare delivery and in research. And so whether you're a member of the public, a healthcare professional, a policymaker, a researcher, or some combination of these, I really hope that this event will inspire you to further develop and raise the voice of patients and their families in all that you do in your practice. And so on that note, I would now like to hand over to Professor the Lord Darzi, a name with which I'm sure many of you will be familiar as a world leader in patient safety. Ara is the Director of the Institute for Global Health Innovation at Imperial College London, as well as having many other prestigious positions, reflecting his long history of visionary leadership and research into the safety and quality of healthcare, both nationally and internationally. In 2002, he was knighted for his services to medicine and surgery and was introduced to the UK House of Lords as Professor the Lord Darzi of Denham. He's now going to outline some of our work at the Institute of Global Health Innovation a little bit more and set the scene for today's event. So I now hand over to Lord Darzi.
Good morning and welcome to the 5th Annual World Patient Safety Day. I am delighted to see so many of you join us for this event. Over the last year, as we have emerged from the challenges of COVID-19 pandemic and faced new challenges and pressures on the health system, it has become ever more important for us to come together and discuss key areas of patient safety. This year, we focused on the crucial theme, engaging patients for patient safety, recognizing the essential role of patients, families, caregivers, and communities as partners in the health system. We can call on all levels of health systems, from national policy level to organizations and facilities, clinicians and healthcare workers, to elevate the voice of patients. As the Institute, we acknowledge the key role of patients and their families in shaping our research and have worked with patients and the public on co-designing interventions, reviewing and being equal partners in research projects, and participating in events, including 3 public partners who co-designed this webinar. We benefit incredibly by the contributions provided by our public partners, who generously give their time with our research partner groups, as well as advisory boards to feedback on projects and strategies alike. Patients support us with identifying the inequalities and limitations of our projects so that we reach more people effectively. In cancer screening, women from underserved groups, including from ethnic minorities with disabilities and from areas of deprivation, ensured a behavioral science cancer screening intervention was appropriately designed. Thanks to this group, the work is now informing strategy in pan-London breast cancer social marketing campaign. Patients have been involved in research studies from the start to finish, including in our medication safety projects, where they have analyzed surveys, debated how the results should be formulated for maximum effect, and have come up with ideas for how best to disseminate the research, including co-authoring our academic papers. Patients have also been equal partners, co-producing research. A diverse group of young people drew on their lived experience to shape a study around the impact of COVID-19 lockdown on their mental health and coping strategies. Young people were trained to carry out interviews and analyze the data. Together, we co-produced a film, Nexus, based on these research findings, an example where we have been responsive to emerging patient safety priorities, as well as paving the way for novel types of dissemination. Carers also demonstrate how the valuable insight to us. In our network data lab, unpaid carers informed us that they did not report they were unpaid carers to their GP, sometimes for over a decade, because they were unaware they should. Their voice demonstrated that we should not assume, but should listen. Involving patients and the public partners meaningfully across the research landscape has led to more impactful and novel research. Public partners have helped us to build relationships with people from underrepresented groups, provide insight into what might cause further harm rather than help, and actually see through the translational impact of research that improves safety and people's lives. The concept of patients and family involvement is well recognized in some areas, but we have to push beyond this and consider how we can involve patients in all aspects of the design and evaluation of healthcare. We must empower patients and family members to become active partners in their care and to feel able to speak up when they feel unsafe. It is essential for us to consider how we can engage with patients and the public who are typically less likely to have a voice in healthcare research and policy making. Patients are the only consistent person in their care. They might have a different observation and insight into the safety of a health system than healthcare workers themselves, and can identify leading causes of harm. We must harness this knowledge through working alongside patients in the delivery of care, engaging them at the facility and broader and board level, work alongside them to develop research projects and co-design health services. We must also listen and respond appropriately to their concerns when reports of adverse events are raised. We will soon hear from Rosie and her experience from an adverse event which had a profound impact on her life. It is essential that we keep the patient voice at the front of everything we do, to remind ourselves the importance of learning and striving for continuous improvement. We will hear from the multidisciplinary panel, including researchers, clinicians, and patients, to understand how patients and families can be engaged in different ways throughout the health system, including how we can better engage with underserved communities and vulnerable groups to elevate their voice in the health system and work along them to ensure care is meeting their needs. I look forward to hearing the discussions and for us all to consider how we can take away some key messages and implement them in our own practices. I would like to thank Henrietta Hughes, the Patient Safety Commissioner, for joining us to share her thoughts on working alongside patients who have experienced harm to find resolution and seek learning from the system. I would also like to thank the Minister and our colleagues at the Department of Health and Social Care for their continual support. I hope you will enjoy our event today and hearing from a fantastic range of speakers, and we will consider how you might work more alongside patients as equal partners in improving the health systems and ensuring safer care for all. Thank you.
Thank you, Professor Darzi. We now come to our second keynote talk, which is from Dr. Henrietta Hughes. Dr. Hughes is the first Patient Safety Commissioner for England. She was previously the National Health Service Speak Up Guardian and provided leadership and support to Freedom to Speak Up Guardians across England within the NHS, independent sector organisations and other parts of the healthcare sector, with a view to making speaking up an important part of business as usual. Now, as well as all these high strategic positions, Dr. Hughes is also very much still connected with frontline practice and continues her clinical role working one day a week as a GP in central London. She was made a Fellow of the Royal College of General Practitioners in 2019 and was honoured with an OBE medal in the Queen's New Year Honours List in year 2020. So, Dr. Hughes, we now hand over to you for our second keynote.
Thank you so much for the incredibly kind introduction and the lovely invitation to be with you today. And I'm delighted to be with you from the WHO in Geneva to celebrate World Patient Safety Day and the remarkable achievements of patients, families and the workforce over the past year. This year's theme, as Lord Darzi said, is engaging patients for patient safety, a theme which really resonates with the themes from First Do No Harm, the report from which my role was a recommendation. But before I reflect on my first year in post as the first Patient Safety Commissioner, I would like to talk a little bit about the Lucy Letby case. I was shocked and appalled to hear of the horrific murders and attempted murders of newborn babies by a nurse in a position of trust, treating the most vulnerable patients. My thoughts and deepest condolences are with the families bereaved and affected by her actions. I'm also outraged that her actions were able to continue after colleagues raised concerns to trust leaders and were ignored, victimised, threatened as a result. And when families raised concerns, their voices were not listened to or acted upon by an organisation whose leaders appeared to be more concerned with preserving the trust's reputation than about keeping their patients safe. What does this say about our health service, and how do we rebuild trust? I've heard many examples where patients and families were ignored and fobbed off, where patients and families have put in complaints, raised matters to the Ombudsman, the regulators, MPs and the press, or litigated to get advocacy so that their voices are heard. And yet time and time again, we hear about obfuscation, cover-up, and lack of transparency and candour. But I was reflecting that at the time of the Lucy Letby murders, I was a medical director at NHS England, responsible for around 3,000 GPs and working with a number of challenged trusts. I'm perplexed that the concerns about criminal activity did not lead to contacting the police. At the same time, my team were working with the police on the case of Dr. Manish Shah, on information about potentially criminal activity first raised to us by a colleague. It led to his arrest, charging, and ultimately conviction for 115 separate counts of sexual offences against his patients, for which he was jailed for life. That's what you do as a medical director. However difficult the content, however unprecedented, however hard it is to believe. You listen to early signals and you act swiftly, bringing in the relevant authorities. To the question of the treatment of doctors who raised concerns, no one wakes up in the morning deciding to be a whistleblower. It's about how the organisation responds. Ignoring, threatening, victimising and putting the responsibility onto the staff raising concerns are clear mismanagement and in my view should be the end of an executive career in healthcare. And yet there's been a huge resistance to tackling the scourge of whistleblower victimisation and a reluctance to use the fit and proper person test to prevent this. What is clear is that we need to see health as a high safety industry with a safety culture where there's a reliable early signal detection and swift action. For this, we need a rebalancing of power between patients and healthcare providers to provide information and to listen to the views of patients and families. We need more consistent reporting and for leaders to have more knowledge and skills about patient safety, so that patient safety is never deprioritised at the expense of financial accountability and operational management. So what can we learn from this as we approach World Patient Safety Day and the theme of engaging patients for patient safety? What I've learned over my first year as the Patient Safety Commissioner for England, we need access to safe healthcare. And this requires the safety culture with a shared mindset for clinicians, patients, healthcare staff, regulators, officials and governments. Working with global partners, it's possible for us to raise our ambition, opening our mind to ultra-safe healthcare in the way that high safety industries have achieved ultra-safe commercial aviation, nuclear and transport. I don't need to tell you why this matters to the patients you see every day. I've heard, as the Cumberledge Review did, horrific accounts of the appalling way in which patients have been damaged by a system which is meant to care for them. We have to change the culture of the health system into one of safety and learning, not just on paper, but in everyday practice. And this relies on psychological safety for patients and the workforce, for patients to get the right information, to be able to consent to treatment, including transparency of information about potential conflicts of interest, and for the views and voices of patients to be central to the design and delivery of healthcare. When patients consent to treatment, they need information and time. Consent should be the end point of conversations about what matters to patients, about the benefits, the risks, alternative treatments, and doing nothing, over a period of time and with shared or supported decision making. We need to recognise that marginalised groups face even greater barriers and unless their needs are met, are at greater risk of harm. And this is due to biases, positional power and the epistemic injustice that diminishes the value of the voices of people who lack power and knowledge. We need improved safety and equity to reduce the burden of the impact on marginalised groups and eliminate disparity by applying the principles of Core 20+5. To ensure the presence and voices of all patients and families. And to that end, I've shared a vision of consent with patient representatives, the professional regulators, NHS England and NHS Resolution. We need improved practice on this, recognising that a third of cases with NHS Resolution have an element of consent, and that there's considerable variation in the approach of different professional regulators. There needs to be greater reliability in the way that patients receive information for all types of treatment and from all types of health professionals. Patient voice needs to be strengthened and listened to rebalance the power differential. I've visited healthcare providers across England, meeting patient safety teams and patient safety partners. I can see a real enthusiasm for making improvements in safety and incorporating the views and experiences of patients. But these steps towards patient involvement are patchy, and many organisations have yet to appoint patient safety partners. A recent report from the Medical Technology Group showed the wide variation between different parts of the country in the way that ICSs are engaging with patients, and it's not clear how this will be monitored or inspected. Patients lack power in clinical environments, and there are too many examples where not listening to patients and families has led to harm or tragic outcomes. People become powerless in environments where the views of families, patients and staff aren't welcome or heard. The Cumberledge Review describes many examples where people who were used to being heard or even to ask forensic questions for a living were silenced in the clinical environment. And a well-known commentator described to me a time when he went to an outpatient appointment. The doctor didn't recognise him or his name, and he was shocked that they spoke to him like a patient. This culture change is needed throughout the health system. I'm calling for a radical rethink of the way that we see the role of patients in the public. The tragic case of Martha Mills, who died needlessly from sepsis, has led to a call for Martha's Rule so that all families can request an urgent second opinion when they have concerns or when they feel their voices are not being heard. I support this innovation, which has saved lives in Queensland, Australia, where it was first introduced, and believe it will be a positive step to amplify the voices of patients and families and to improve the way that patients are seen as part of the team. I'm honoured to have been asked to lead a programme to implement this by the Secretary of State. A recent infographic outlining the health system showed patients at the bottom as passive recipients of care, depicted as frail and needy. At the top of the diagram is government, which provides money to the system. I contest this description as the money comes from citizens. The vast majority of the £1 trillion revenue is collected as income tax, national insurance and VAT. Therefore, the citizens are the customers and the shareholders of the National Health Service, and the government is accountable to its citizens. So why do we cut them out of the conversation? The National Patient Safety Strategy calls for patient involvement after incidents, and many organisations are currently introducing PSERF, which I welcome. But it's not enough to learn only from incidents. If we're committed to learning from situations where things haven't gone as planned, we need an overhaul of the National Complaints Policy. There are no winners with the current policy. It puts the burden on the patient and sets up an adversarial approach. We need to move away from oppositional stances which lead to inadequate, defensive and insensitive responses from NHS organisations when concerns are raised, compounding harm with a devastating impact on patients and families. The current complaints process also creates anxiety amongst NHS staff and the leadership who operate in a blame culture, not a just culture. Reporting to boards is more about the number of complaints and how quickly they were handled, rather than focusing on the seriousness or the content or the impact. Due to a fortress mentality and lack of transparency, or even cover-up, families resort to litigation to get the advocacy they need. And there's no national learning from complaints, so the same problems recur up and down the country. This is in contrast with incident reporting, where there's a swift and responsive protocol to share learning nationally. The gap between the response when an issue is raised reinforces the injustice that the views of patients are worth less, or are even worthless. We need a new way of working to maintain the relationships between patients and those caring for them. In New Zealand, a restorative approach is being taken, and there are great examples of this in England, pioneered by Merseycare. We should be asking, who was harmed? What do they need? Who is responsible? What are their obligations? How can things be put right? And how can we prevent this from happening again? Many organisations, including AVMA, the Harm Patients Alliance, NHS Resolution and the Parliamentary and Health Service Ombudsman, are calling for a less adversarial approach. I'm calling on the Department of Health and Social Care to overhaul the complaints process, to improve the experience of patients and families, improve staff morale, and to embed the learning from complaints into improvements across the NHS. But with so many initiatives to support patient safety underway, what strikes me is that in England, the factors needed to keep patients and families and staff safe, which rely on leadership and management commitment to safety, are sliding backwards. Concerns about patient safety are not exclusively a problem in England, and I've had the opportunity to learn from international approaches. A major difference that I've noticed is that outside England, patient safety is fronted by the leaders of health provider organisations, whereas here we rely on a network of positive agents for change who sometimes struggle to get their own voices heard. We need senior leaders to be knowledgeable, skilled and experienced, and professionally curious about the experience of patients in their care. The NHS Improvement Patient Experience Improvement Guide states, where the board heard a patient story at every meeting, the executive and non-executive directors appear to have an understanding of patients' experience. But neither the boards of NHS England nor the Department of Health and Social Care hear a patient story. Leaders need to be highly visible and uncompromising about excellence, respect and dignity to demonstrate their commitment to safety. I'm delighted that the Secretary of State is genuinely interested in ways that patient safety can be improved. This will enable senior leaders in health to focus on patient safety alongside other priorities. The focus on the training, support and knowledge for non-executive directors in the recent ministerial statement is to be applauded. These vital roles are the last line of defence in ensuring that health providers and systems keep their patients safe. But fundamentally, we need to operate the health system as a high safety industry. Commitment to process safety requires leadership, commitment and responsibility. We will not be able to see the benefits of the Patient Safety Incident Response Framework and the recommendations from HSIB and other inquiries without this vital first step. This will only work in a just and learning culture. There's a widespread consensus that we need to systematically listen to the people who know the service best and invest in creating a workplace culture in which they feel valued. But leaders don't appear to understand when people don't feel safe to speak up or to give evidence to an investigation. Our responsibility is to help healthcare workers avoid and eliminate harm. But we won't achieve this by blaming workers, but instead by adopting safe practices that help patients and clinicians. As Don Berwick says, you would have to fly continuously in an aeroplane for 6,000 years to be in an aeroplane incident, but 1 in 4 patients has an injury from healthcare. You are 2 million times safer in an aeroplane seat than a hospital bed. We need to learn from commercial aviation. The airline industry achieved this by adopting systems and processes such as 100% compliance with pre-flight checks, scheduled maintenance, teamwork, and a culture where people can report mistakes and speak up if anything's wrong. And airports refuse an airline to land if the pilots are not sufficiently trained and experienced. Its systems are designed to help make fewer mistakes and to spot errors. But we need to do this with the full cooperation of and with an respect for the healthcare workers. But I ask myself, is the problem that we're normalised to harm? Or is it that health is such a complex adaptive system that it's not easily comparable to commercial aviation or the nuclear industry, or we lack data? Is it a psycho-political issue because there's no straightforward fix and the reality that people are harmed, that children die avoidably, is too difficult to comprehend or be accountable for? Or maybe that with the overstretched and exhausted workforce asking for more is too much. I refute this because as a doctor, I feel more stressed if the systems I'm working in are unsafe by design, but more confident when I feel valued and listened to. We need fully reliable care, not as the exception, but as the rule, with systems co-designed by patients and staff. We need to invest in the science of safety to harness the power of data in national systems and work collaboratively. We need to approach safety as commercial organisations do. And when it comes to finances, we need £2.2 billion for the workforce plan, the same amount as the cost of medication errors every year. We need more beds and more staff, 186,000 beds are taken up each year by patients who've had a medication error. So improving safety could improve outcomes and free up resources at the same time. We know the moral argument, the human argument, and the economic argument. What we need now is for a safety culture which engages patients for patient safety to make the NHS the safest healthcare system in the world. Thank you very much.
Thank you very much, Henrietta. So much food for thought there, and some themes that I'm sure will resonate with many of our attendees. Now, Henrietta highlighted the importance of hearing patient stories. So we're now really pleased that Rosie Bartel is going to share with us next some of her story. Just to introduce Rosie, Rosie is a patient advocate. She is a widow, a mother, a grandmother, and an educator. In 2009, she underwent a routine knee replacement operation that developed into a healthcare associated infection. This led to 58 operations, 200 hospitalizations, 100 blood transfusions, and a leg amputation above the knee, followed by further extensive surgery. She's experienced sepsis and septic shock 14 times. So Rosie continues to battle the effects of this infection in her body, and at the same time, she is driven to share her story with us and with many others. She believes in helping patients and caregivers to find their voices. As an educator, she is used to using stories to teach children and adults, and now today she uses her story to co-design with medical professionals and researchers and to advocate for patients and their caregivers. So Rosie, we're humbled that you're willing to share your story with us today. So I now hand over to you.
Thank you and welcome. I'm glad to be here today with you, all of you, and privileged to be part of this wonderful day with you. My story, as you said, began in 2009 when the word co-design didn't have many, I don't think anybody said those words very often. And I did wake up from a surgery that wasn't quite the same as other surgeries I had. I have rheumatoid arthritis. So this was my 5th joint replacement. I thought I knew everything about joint replacements, but very quickly I learned that this one was a little different. And so by the time they were removing the staples about 2 weeks later, I was having drainage. Originally, the doctor said, oh, it'll go away once the staples are removed. Well, it didn't go away. By the end of that weekend, I was wrapping my leg in beach towels and I was waiting for the Monday morning to come around so I could call the doctor to say there is a big problem here. What happened then on Monday was I came into the doctor's office. He looked at me and said, oh, I think I have a little bit of time to change out the hardware and everything will be okay. Well, I went the next morning to the hospital at 5 o'clock in the morning. At 7 o'clock in the morning, they changed out the hardware. I don't remember that day. I believe that was probably my first time in sepsis and septic shock. But the next morning, I remember meeting a strange doctor, a new doctor. He was an infectious disease physician. He looked at me and he said, lady, you're very ill. You have a MRSA staph infection, and I give you about a 30% chance of surviving this. He might have said a lot of other things, but those were the words I remember. And those are the words that stuck with me. And I kept thinking, you don't know me. I have survived 3 types of cancer. I am a survivor, I don't give up. But after he left my room, very quickly, I realized that I wasn't able to function. I wasn't able to focus. I wasn't able to communicate very well. I was definitely having lots of problems. About 2.5 weeks later, I finally left the hospital. I had been back to surgery multiple times already in those 2.5 weeks. And I knew very quickly that things were not going to be right. What happened, though, was that as I was working with this doctor who gave me a 30% chance of surviving. At first, I didn't like him very much. I kept saying to him, I need to know why this happened to me. I really need to make sure that this doesn't happen to someone else. And about 6 months to 9 months into me saying that over and over to him on my bi-weekly and tri-weekly visits to his office, he said to me, Rosie, we know we have a problem in our hospital and in our healthcare system right now. And we know that we're having way too much MRSA in joint replacements. And we pulled together a whole team of people to study it and to spend a whole week looking at why it's happening and what could be causing it. And he said, but we have never invited a patient to the table. But I think you're the patient we need today. And you're the patient we need to have at the table. Would you come and spend the week with us? So literally, I went every day from 8 to 5 to the hospital and spent the day with people from pharmacy to help nurse practitioners, to doctors of infectious disease, to physical therapists. But I was, from the beginning, my voice was just as important at that table as everyone else's voice. And I have to tell you, I learned a lot. I learned all the different ways I could have gotten this infection. And it wasn't just by, the surgeon. It could have been by, how they cleaned the room or how the surgery, the OR suite was cleaned. I learned lots of things. On Thursday evening, the doctor said to me, Rosie, tomorrow morning, we're going to present our findings and our requests to improve this to the leadership. But if they don't hear your story and we don't have you with us, none of the things we think we need will happen. So very quickly, I said, yes, I'll share my story. I was a storyteller. I love telling stories. And so I said, yes. Now, I thought when he said leadership, I might be in a room of 20 people. Well, it turned out it was a room of 200 people. But I told my story, and then we shared our findings from the week. And needless to say, every one of our findings and all of our needs were met. And I remember him following me out of the room that day and putting his arm on my shoulder. And to this day, I can feel his hand on my shoulder. And he looked at me and said, Rosie, this is what this leadership needed to hear. They needed to hear what one infection and what one person experiences when they get an infection. Well, that was the beginning of me telling my story. And I very quickly decided that this was my new role in life. I needed to tell my story to anyone who was willing to listen to it, and especially if they're willing to create change. At first, I told my story a lot around hand hygiene and about hand washing and hand sanitizing and all the different ways of monitoring hand hygiene. I remember going to hospitals and healthcare organizations, and they're saying to me, Rosie, we were at 45% compliance, but now we're at 65%. So I think we're doing really good. And I would say to them, hey, I'm an educator. You're failing. That's a failing grade in my book. And so please, let's all be at 100% hand hygiene. But then I started thinking about all the other ways I could have gotten this infection. It might have been an environmental service process where someone didn't clean well. Maybe they didn't change filters when they should have in facility. So very quickly, I'm like, I need to tell my story to other people in the healthcare profession. And so now I tell my story to people that are in environmental services. I do tell my story to maintenance, to security, to construction. Let's face it, when somebody's doing a remodel job in a hospital, they're also creating dust and particles that we can't even see, but yet we're dragging them all through our hospital because we don't always think about why it's so important to make sure that that doesn't get taken from that construction area to other parts of the hospital. So every day I look at how can I share my story. Every day I look at it from the point of view of how do I share it with purpose. And that means that when someone comes to me and says, Rosie, would you tell your story? I say to them, why are you asking me to tell the story? What is the purpose of you having me tell my story? And then I also tell them, and if I'm going to tell my story, that means I'm going to be with you in this journey of whatever you're doing. I'm not a one and done kind of gal. I'm the kind of person who wants to see results, wants to know that it made a difference. And so as I mentor patients and other caregivers to share their story, I also mentor healthcare providers and people that work in healthcare to be co-designers. And we didn't know that word, and we didn't use that word until 2010. But today, I believe that that's one of the most important words in the healthcare profession, and it's the only way that we're going to do the things that Henrietta was talking about. I thank you for listening to my story today, and I hope that I might hear from you or be able to tell my story in a greater degree at some point along the way.
Rosie, thank you for sharing your story with us. It's hard to even begin to imagine what you have been through on that journey, and we're really grateful to you for sharing your journey as part of our journey and sharing your experiences with us today. Thank you. We're now going to take a short break for about 5 minutes. We're going to use this opportunity to share the first of 2 canvases that our illustrator Chris Shipton has been creating. So you're welcome to look at that on the screen now. And if you need to stand up for a couple of minutes or take a comfort break, this is your time to do that. We're going to restart again at around 11:48. So please do be back at your screens before then. See you soon. So I hope you all had a chance to have a look at that fantastic illustration from Chris, and there'll be another one of those to follow later on. We now come to our panel discussion. Now this will be chaired by Dr. Tessa Richards. Tessa is a medical editor and a long-standing patient advocate. She actually led the BMJ's patient and public partnership strategy for many years and continues to support its spread across the whole of the BMJ portfolio of journals. She's an absolute passionate advocate for patient empowerment, shared decision making and co-design of health policy and practice. She has worked as a general physician, as a rheumatologist and as a general practitioner before she joined the BMJ. She lives with stage 3 adrenal cancer and ischemic heart disease and is a carer for close family members with rheumatoid arthritis, cardiovascular disease, dementia and blindness. So Tessa brings a really unique set of experiences and we look forward to your chairing this session, Tessa. Thank you. Tessa, would you mind just unmuting?
Thank you. Thank you very much for your kind introduction, Bryony. I think I've led a charmed life. My time in the NHS was at a time when it felt very buoyant, a lot better than it does now. The journal has been an incredible career, and it has been the privilege of my life to lead the BMJ's patient and partnership strategy. And I think what's made this so incredibly innovative was the way that we decided from the inception that we would work with a team, an international team of patient and public advisors on what we needed to do to make ourselves credible as a journal in terms of responding to the patient's needs and listening to their voices. So they had some wonderful ideas initially, like sack all the editors, put us patients in charge. But we moved towards this co-created strategy, and we continue to work with our patient and public advisory panel every step of the way. And some of the innovative things we've adopted are to send papers for review by patients as well as by peers, scientific peer review. You mentioned that I've had a parallel journey as a patient during what we call the BMJ's patient journey. And over this time, I have to say that my work with the patient's carers and patient advocates has helped hugely to empower me as a patient and to know how to reach out to help yourself as a patient and advocate for those who you love and care for. It's hit home to me how much the quality and safety of my care depends not just being informed about my medical conditions and self-managing them to the best of my ability, but getting my voice heard. And that is really hard still. However articulate you are, however empowered you are, it can be incredibly hard, not only to get your voice heard, but your views taken seriously by the many different health professionals patients routinely interact with, not only face-to-face, but now increasingly virtually. It's therefore a great privilege for me to chair this panel session to debate how patients and families, including those from underserved groups, most particularly, they can become engaged and actively involved at all stages of their care to improve its safety. And during this session, we'll be posing questions to our 4 panel members who've got very wide experience of different aspects of patient engagement and safety in healthcare. Professor Jade O'Hara is Professor of Quality and Safety in Healthcare at Leeds University and Deputy Director of Yorkshire's Quality and Safety Research Group. Professor Amanda Ullman is Professor of Paediatric Nursing at the University of Queensland, Australia, and Chair of Paediatric Nursing at Children's Health Queensland, which is a statewide network of children's services. Asmahan Al-Nidawi is a patient safety partner at Imperial College Healthcare NHS Trust. Dr. Michael Ramsey, a former consultant anaesthetist, is CEO of the Patient Safety Movement Foundation, which is a US-based not-for-profit organization whose mission is to reduce the current high level of preventable medical error and harm globally through the adoption of evidence-based solutions. So welcome to you, the panel members, and I'd like to start with asking each of you to briefly tell us a bit about your work and what your organisation is doing to increase patient and public awareness of the problems around medical safety in care and in helping patients and their families get actively involved in helping this mission to make care safer. So Jane O'Hara, can I go to you first?
Thanks, Tessa, for that introduction as well. So as you say, I'm Jane O'Hara. I am a Professor of Healthcare Quality and Safety. I'm based at the University of Leeds, but I'm a long-standing collaborator with a group called the Yorkshire Quality and Safety Research Group, which is based at the Bradford Teaching Hospitals Trust. I've been a patient safety researcher for the last 14 years, and really one of my central research interests has been how we engage patients and families in healthcare safety. So I've looked across a range of different aspects of how patients and families might help support their safety, but also the safety of care. And I think one thing that I'd like to highlight, perhaps not least because we're launching it today, is some work that we've been doing called the Learn Together programme. Which has been running for the last 4 years, and we've tried to work with a community of patients and families, researchers, also other academics, managers, practitioners, a whole community of people to try and co-design, as you say, this is so important, to co-design new ways of actually supporting patients and families to be involved in the investigations that happen after patient safety incidents. So that work is being launched today, and I can talk a little bit about it later if anyone's interested. But as I say, very happy to be here and to talk about the work that we've been doing and join in the discussions.
Coming now to Asmahan. Sorry, Asmahan Al-Nidawi, could you kindly take over from here, please?
Hello. Hi.
Hello, can you give us a little background on yourself and what you're doing?
Yes, I become a patient safety partner because I used to suffer at time from difficulties with language and confidence. So I have also undertake this role to support my community. And I gain like experience with NHS and help their system. I start make like slowly make good relationship with my community and encourage them to talk about their stories and experience. But they weren't, in the beginning, they weren't happy to tell the story. And I was telling them, if you don't tell your story and don't talk about it, how we improve the service. So, we're planning to do like a workshop to talk to the community about the patient safety, and maybe we will do it in autumn. And we are 6 of patient safety partner at Imperial, and as a group, quality, diversity, and inclusion is at the front.
Thank you. That's very helpful. Thank you. I realise how hard it must be for you to talk with us. The English is not your first language. Thank you. You've done a brilliant job. Amanda Allman, can we go to you next, please?
Absolutely. Well, good evening, everyone, and thank you, Tessa. It is a privilege to be joining you from Yagara and Turrbals people land in Queensland, Australia, where, as you mentioned, I'm Professor and Chair in Paediatric Nursing across the academic and health services. I am a paediatric patient safety researcher specialising in clinical trials, co-design and implementation science. One of my greatest privileges is to be Director of Child Unlimited, a consumer-led Australian network of researchers, clinicians, advocates and families with a shared vision to improve the clinical care and quality of life for children, adolescents and young people living with chronic health or disability. And just this week, it culminated with an event at the Australian Federal Parliament. This is an event that was completely organised by our Youth Consumer Committee, and with their energy, enthusiasm and just general cleverness, they managed to get 30 parliamentarians to come and listen to where they thought health services needed to be improved to better meet their needs. And it's been such a privilege to work with them over the last little while. So thank you for the opportunity of meeting with you all today.
Thank you very much, Amanda Allman. And now can we hear from Michael Ramsey a bit about your work?
Certainly, thank you. It's a great pleasure to be here, great honor to be here. I'm a clinician, a physician trained in London, and went over to Dallas, Texas. You think you speak English, it's two different languages when you get over to Texas. I had to relearn how to speak when I got there. But I ran the anesthesiology department and I got on the board of trustees. And for the last 10 years, we've had a real focus on patient safety, trying to create a patient safety culture in the institution. So suddenly everybody in the system had to write a commitment to patient safety, from the chief of surgery to the janitor. Everybody involved in the hospital, in the healthcare system, had to do that, and it was published. And things that were investigated in the past were kept confidential, no longer confidential. I know what the infection rate is in the hospital. I know the last time a foreign object was left behind in a wound. That's all now knowledge that's transparent. So we made a difference there. I retired 18 months ago and became CEO of the not-for-profit Patient Safety Movement Foundation that was started in the United States. It's now global. Our chair of our board is Dr. Mike Durkin from Imperial College here in London. We were at the World Health Organization meeting this week with Dr. Hughes. I'm leading a march from the White House to Washington, D.C., the Capitol, this Sunday to promote patient safety, where we're going to place orange flags on the lawn outside the Capitol building. And so I'm deeply involved in trying to make a difference. I think with us all working together, we're going to be able to do it, because finally, I'm optimistic there's momentum coming on. We're becoming more transparent about the problem. We've got patients engaged. Rosie's talking to us today. That's very important that we have the patients engaged, because that's what it's all about in making healthcare safe. We have to hear the patient stories. So thank you for the invitation.
Thank you, Dr. Michael Ramsey, and great, we're with you if in spirit on your march, even if we can't all be there alongside you. I'm now going to pose some questions to the panel members, and start, if I may, with you, Jane O'Hara, which is, what do you see as the main barriers to actually involving patients and their carers in patient safety initiatives and research, and which groups do you really struggle to engage with, and what are you doing about that to sort of improve that engagement?
So thanks, Tessa. So I think it's useful just to reflect, before I answer that, exactly the sort of three main ways that I always think about patients and families being able to support their care and the safety of the care. So the first way is that they can tell us about things that have happened, so things that have happened in the past. And we know from worldwide research, but also some research that we've done locally in Bradford, that we can gather general concerns from people, and we can we can use that information to improve the safety of services. As I've mentioned just when I introduced myself, you know, the work we've been doing locally for the last 4 years has absolutely shown me, and I think our team, that patients and families are really a key part of the jigsaw to help us understand what has happened when something specifically has gone wrong, where there's been a patient safety incident, and they absolutely have to be part of a wider sort of investigatory process where something has happened. So we know that people can tell us about things that have happened. We also know that people using services can tell us about things that may happen in the future. So there are whole ways, a series of things, you know, that people could tell us about if they've been in hospital or received some sort of healthcare. They can help us understand, you know, contributory factors, if you like, to future error happening. So it's really important to speak to people about that. And then the final thing, I think, and you know, that's partly what you're talking to me about, is that I think it's really important, and we've heard already from the other panelists, to work with patients and families and the public to help us co-design services so that they really are based on their experience, their needs, and the safety gaps that are sort of illuminated only by looking at those experiences and needs. And then when we look across all of that, I think it's certainly, there's been some work academically that's been done, and there's been various different reports over the years about different groups of people or different populations that may be more at risk either of safety incidents, but also less able potentially to support service improvement around safety. So things like not speaking the native language is a real indicator for the likelihood of being more likely to experience a safety incident. And so it's really, really important that we don't just look to hear from patients and families that usually get involved in service improvement or are able to get involved in the ways that we want them to. So it's not good enough for services just to have a focus group or you know, do all those sorts of perhaps traditional things. I think it's really, really important, and I think we'll be hearing from colleagues in a moment about this, to actively start to build relationships with communities, local communities, national communities of people, so that we can understand what their needs are relating to healthcare and what their safety concerns are. We have to go out to them, build relationships so that over time we can really genuinely build and co-design services based on their needs and our understanding of their needs. So I think there are barriers, but I think we're increasingly understanding that, particularly with community-based approaches, we can start to both understand what those barriers are and support ways in which we might improve services to get around some of those barriers.
Thank you for that. May I just interject with a couple of questions?
Of course.
You know, when you get anything, when you buy anything, when you're experiencing anything, you get a little text saying, what did you know, give us some feedback. Now, it seems to me that you get the friends and family test if you go into a hospital in the UK, you have the opportunity to use patient opinion, but no one actually says in those contexts, they'll ask you specific questions. Did you feel safe during your hospital stay? Do you have any suggestions for how things could be run more smoothly, improve the quality and safety of care for other patients on the ward? No one's ever asked me that question, and it certainly doesn't appear in the friends and family test. No one has either said to me, right, we're discharging you from hospital, you know, please give us your thoughts via care opinion about the quality and safety of your care. Any thoughts you may have? You've been lying in a hospital bed for a week, observing staff come and go. Seems to me, you know, we're very good about saying this all should happen, but we're not so good about systematically making it happen at this kind of grassroots levels. We sort of say we want feedback, but I wonder how serious we are about that. And that mostly we're wanting feedback to say, I had a very nice time, thank you, so we can give ourselves 5 gold stars on a website. What do you think about how we can systematically get better at collecting feedback?
Well, you make a very good point, Tessa, and a lot of the work that we've done in Bradford down the years has been trying to capture reports from patients, so information from patients and families, to more systematically support or rather to support services to systematically engage with that feedback. So we do have validated ways of doing that. I think we've really struggled to really get those embedded in services, and there are lots of reasons why services why it's difficult to get sort of systematic response to patient and family feedback, and a lot of it, and this is, I suppose, if I say one thing at all in this this panel Q&A, it will be that actually whatever we do, however we try to support patient and family involvement, we absolutely need to look at the system into which it is going, because so many good ideas, as you say, Tessa, fall by the wayside because we don't understand how these things might actually operate in health services. So it is my plea to everyone on this call to think not just about calling for things, but actually try to support evaluation of services, you know, making changes based on patient and family feedback, and really understanding why it is that organisations, healthcare organisations, struggle to respond to feedback, to involve people in service improvement and the like, because I think there are things out there that have been developed. There's lots of ways that patients and families might be asked for their feedback. It's just that they have failed to be systematically applied in healthcare settings. So I think it's as much about doing new stuff. It's as much about, you know, let's think about the new stuff, but actually let's really understand why things have failed in the past and what the sort of fundamental foundations are that can support organisations to systematically hear from the voice of patients and families.
Yeah, I think it's also an issue around, you know, the patient experience library collects a massive amount of data.
Indeed.
You know, using the data that is collected, a massive amount of which is not systematically analysed and used.
Yes.
But Asmahan Al-Nidawi, could you give us a view on what the underserved need from the healthcare system if they're to be empowered and supported in improving their own safety?
Okay, it is like explain things clearly and in different languages, make care easy to access, treat people well and respect their culture, help them navigate the system, and involve them in healthcare decision and policies. I think this point would be by doing this thing, the healthcare system can help underserved group feel safe and empowered in their own healthcare.
Thank you very much for that. Taking the perspective of the health professionals, Michael Ramsey and also Amanda Ullman, if I could ask you in turn, you know, it's when you go to nursing college, medical school, whatever, I don't think, you know, there's a lot of education about how best to work with patients, how to engage with them, how to listen with them. And I think health professionals, you know, they're more used to dictating to them and advising them than listening. So how would you advise people who are not very used, this is health professionals, to engaging and involving patients in patient safety initiatives or so, you know, how do you go about it? Is there good guidance out there that you can offer to people? And do you have any sort of top tips about how health professionals can do this better? Michael, perhaps we could start with you.
Sure. I think the problem in most hospitals and most healthcare systems is the patient isn't the number one, and the patient should be number one. It's the clinician. You know, the patient has to sit there waiting for the clinician to come. The nurse is setting up the chart, getting the computer set up. The physician is busy. He's late coming into the room, comes in, maybe acknowledges the patient, but then quickly gets on the computer. It's not about the patient, and it has to be about the patient. We have to change the whole culture in healthcare and make it all about the patient. The patient is number one. That's who we have got to talk to. When we come into the room, we've got to interact with them. We've got to find the right way to interact with them. Maybe it's take your white coat off and sit down with them, but we have to make the patient number one. And unfortunately, the patient isn't number one in most healthcare systems. And we have to do that. That patient is nervous. They don't remember a word you say because they're frightened, they're uncomfortable, they're stressed. And if we can make them relaxed and feel that they're so important to us, that that's why we're there, I think things will change. And I also think patients should bring somebody with them who they trust, can be their wingman, because they are under stress. So they're not really listening to what the nurse or the clinician's saying. They forget very quickly what they've been told, instructions. They need somebody with them as their wingman to really make sure they've got notes, they've taken notes, and they've asked the right questions. But really the culture has to change. It has to be all about the patient, not all about the doctor.
Thank you. And what you're saying is a sort of return to old-fashioned values and approaches. You know, it's the doctor who maybe sits by the side of your bed rather than the one who shouts at you from the end of your bed, which is certainly is my experience as a patient is what normally happens. And who sort of levels that gap between you and brings some humanity. And I think the trouble is, you know, apart from staffing shortages of the way people work nowadays, everything being inputted onto the computers and stuff, but it's I think there is much in what you say about some of the simple things and cultural changes that would make a real difference to patients and make them feel that the health professions are really on their side. Amanda Ullman, I'm sure you have views on this.
Yeah, absolutely. So thanks for the opportunity to talk about that. I think about this quite a lot, and I think really practically about the clinician who is probably listening today are the people who really do have the good intent to want to listen to their patients. They really do have the good intent to want to partner with them, but sometimes they're thinking about the big picture of all the big cultural change that needs to happen, but what's that first step that they can make to ensure that they can be that person. So everything that Michael's just said is absolutely true, but also thinking about a patient safety in everyday practices all the way through to systematic reform. How do we go about doing that? So on that spectrum, and then thinking about the varying levels of engagement. So I do think at the core it's about trusting our patients and enabling them to become true partners in their care. And I really do think about thinking practically first, looking at those critical moments like handover, infection prevention, hand washing, looking at that as moments, as discrete safety tasks, and targeting patient safety interventions that can enable patients to become the partners in there. So we know that bedside handover, for example, is a prime opportunity for patients to engage and to identify areas and information being handed over and add to the content of communications, but they do really need to feel prepared to have those conversations. We need to provide practical resources. So we talked about a partner coming with them for these conversations, but every aspect of education needs to be targeted at varying literacy and health literacy levels. So ensuring you include simple visuals for education will really help break down some of those barriers many of our speakers have been talking about. And then get ambitious. When you're starting to think structurally, you're thinking about a policy update. We've been speaking a lot about co-design, but how do you start doing that? It's about that bravery of stepping outside of your office and walking into your clinical setting when you're thinking about embarking on the policy redesign. Get creative about how you make those meaningful conversations to ensure that what you're going about doing truly meets those patient needs. And the focus, like Jane said before, really needs to be on building sustained and trusted relationships, especially for communities and people with vulnerabilities, so that we can work towards true leadership in our patients when we're undertaking our patient safety agenda at a systems level. And it takes a lot of time, it takes a lot of energy, it takes a lot of cultural approaches, but it's exciting to see how that can go about changing. I see in the UK the James Linder Alliance priority setting partnerships and how they're now being used to create patient safety priorities that are led by consumers. So the future is really looking bright when you see some of these structural investments that can be incorporated.
Thank you. So I'm very interested to hear about the JLA, the priority setting partnerships around patient safety. One of the best days I ever spent was working along with researchers, clinicians, patients on, top questions to address in patients with multimorbidity, and the safety issues there are multiple because you see so many multiple different providers and things. And I think it's a marvelous way to get to that community of people together and reach consensus in a way that you never think that you will. I wonder if I can turn now, please, to ask your views about how we spread the learning. Everybody knows, there are pockets of marvelous practice, wonderful examples, trusts which have implemented a lot of the recommendations around patient safety and patient safety partners, others that haven't. So, Jane O'Hara, do you have views on how we can spread the learning, how we can best do that?
Yes, so I think there's kind of two main types of learning that we need to do. I think we need to be better at learning across the NHS and healthcare organisations more generally. And I think there are some brilliant examples of sort of bottom-up, grassroots networks of people who are, for example, a network called the Patient Safety Manager Network that has sprung up over the last couple of years, attended by people in their hundreds who are trying to undertake patient safety activity within their trusts. And what that's shown me, I think, is that when people are given an outlet to talk about the difficulties of trying to make change around patient safety in organisations, they naturally kind of coalesce together, and these sorts of communities of practice have been so instrumental, I think, particularly within NHS in England recently with the introduction of the new national patient safety policy around incident response, and those things have been a massive supporting source of support for people to share learning and just to sort of normalise some of the challenges as well around implementing this stuff. And I think there's also something, as Amanda's talked about and you alluded to as well, Tessa, around international learning. So, we don't exist in a vacuum. Healthcare has international, global challenges at the moment. So whilst we might sort of look inward and think that our issues are parochial and just based, in our own countries, there are lots of different conversations, similar conversations happening across global healthcare systems and economies. And the work that I've been involved in recently, the Learn Together programme, I think is a really good example of that, in the sense that from that work I met academics and practitioners across the globe who were looking towards trying to support more restorative approaches, as Henrietta Hughes talked about earlier, support more restorative approaches and less adversarial the nature of sort of how we respond to incidents when they happen. So I'm part of this sort of global network of practitioners and patient advocates and researchers, and it's been so instrumental, I think, in supporting not just the work that we've done, but also I'm so delighted, that we've been able to actually influence national policy with that work. So it's come from, outside England, from the variety of different work that's been going on internationally, and actually gone into our national policy. So I think really supporting conversations between people. It sounds old school. You talk about going back to the old school. I think this is true. It's about building networks and relationships across countries of people interested in making change, and then thinking very critically about how we take an idea from one particular place and whether we can bring it in and adapt it and use it within our own particular situation. So I don't think there's any magic around these things. I think it's about building the networks, building the supportive relationships, and supporting people, I think, to have those ongoing conversations. And you know, there may be a role, I guess, of policymakers or healthcare agencies to support some of those conversations. And I know that World Patient Safety Day is certainly one of those places that we kind of come together and coalesce around these sorts of discussions. So it's a good example of that. Thank you. I just, you know, have concern there's all these well-meaning loads of networks and initiatives and people talking in rooms. I think I'm with Michael Ramsey on the going out in the street. I mean, do you think that there is enough sort of general awareness about safety in healthcare, the importance of it, and for everyone to be involved with this? And if so, how do you go about this, and how do you support people without the confidence to join a network or speak up? I mean, maybe Asmahan, you know, how do we reach the communities that you work with and convince, you know, and give them the confidence to sort of speak up and join some of these wonderful networks that exist and get their voice heard? Sorry, we lost Asfahan. Maybe we have. Okay, just while I think we're waiting to get her back, Amanda, do you, Ullman, can you give us your thoughts on this?
Yeah, I feel your frustration. I was meeting with the American ambassador the other day for a Fulbright, and she asked me what I do for a living, and I told her I work on pediatric patient safety, and she asked me about children falling out of chairs for a lack of seatbelts in hospital. So this fundamental lack of understanding by people outside of our discipline, especially those big decision makers, is still a huge concern. So I'm definitely with you, Michael. I can try to meet you for some street action at some stage, but we definitely need to bring in the consumer voice in the loudest possible way. But I do think international collaboration, and I hugely see the value of networks and meetings like today to both feel inspired and engaged and to share gains. I don't think you can undervalue the role of formally disseminating work. I do think we sometimes have an under-focus on peer review publications. I think, you know, this idea is that real research in comparison to quality improvement. I think there's some amazing projects out there that are not quickly disseminated, and probably some increasing academic infrastructure to ensure that is supported would be very useful. I do see, of course, the value of the internet. The one with the loudest voice on the internet gets their patient safety learnings known. So if your healthcare system or your community system has great patient safety initiatives, make sure they are externally facing so that others can see them. I know that is actually a lot of work to work with your leaders to see value in that transparency, but it's a very good indication of a safety culture if they feel brave enough to do that. And the other little thing that I think we should focus on is when we're talking about patient engagement is we must have good patient engagement training for our patients. We talk about people with varying health backgrounds, varying backgrounds of language and others. How do we ensure that they are properly engaged to have an equally loud voice in sometimes big rooms? So we can disseminate those training programs and share them between institutions. We have done that in our Child Unlimited work for our youth mentors, and are very happy to share, and I'm sure many others are. So we need to think practically about resources to improve engagement, and we do need to think politically. Thanks.
Thank you very much for that, Amanda Ullman. I can tell you that, you know, as a swimming in the patient advocacy world, liaising continue with the BMJ's patient advisory group, a big issue is patient leadership, and how slow it's been for example, in the UK, for NHS trusts to appoint paid patient directors for patient experience, patient's quality and safety, it seems to me that you do need to support the concept of patient leadership. Not every patient can recite their own history and story, and it's a valuable experience, but you also need people who are experienced, if you like, I think, professional leaders, and there are some, and there are an increasing number in patient safety with the WHO Patients for Patient Safety networks who do the most impressive work, and maybe we need to strengthen such networks, internationally, nationally. But Michael Ramsey, sorry, you haven't had a chance to weigh in on this.
Oh, I think I want to support what we just heard. We need transparency in healthcare. I think maybe the NHS has better transparency than many other healthcare systems, but certainly in the United States, it's not transparent. Hospitals underreport. They don't want to report bad outcomes. They don't want to report mistakes. They don't want to lose reputation. They don't want to lose patients coming in. So patients in general are not aware of some of the statistics we heard from Henrietta Hughes earlier about it's a quarter of patients have an adverse event in most healthcare systems, and a quarter of those is a preventable adverse event. I mean, that's big numbers. We think in the United States it's somewhere around about 300,000 patients are lost every year from something preventable. That's like airplanes coming out of the sky and crashing almost every day. That would get your attention if you knew the numbers. So we have to have transparency. People underreport, and I think with AI coming out now, electronic records, we're going to get those numbers. We're going to be much more specific on poor outcomes. They're not going to be hidden anymore. We're going to be able to see them, and that will make us change. It'll force us to change, because then the public, we did a survey in the US, and 85% of the general public thought that healthcare was safe. 85%, not aware at all of the preventable harm that goes on. And yet we know now it's very significant, and yet the general public doesn't know. So that's part of the reason we're doing the march on Sunday, that we want to bring it to the public's notice. But I think hospitals should report their outcomes. They're frightened because of medical legal reasons, reputation. That should not be allowed. They should report. I mean, we used to do root cause analysis of a bad event in the hospital. A root cause analysis would be a small committee that would investigate. They'd come up with a conclusion, but that conclusion was never published anywhere. Even the rest of the healthcare staff in the same hospital were not aware of the outcome, what harm was done, and why was it done, and what could be done to prevent it. It was hidden, and that's totally wrong. The hospitals, as part of a culture of safety, have to be transparent. Transparency is number one, because boy, once you know your data, people change. We're all a bit competitive. If I know my infection rate after a surgery is X% and it's above average, I'm going to change immediately. I'm going to bring it down. And I've seen that happen in my own system, where they became transparent 10 years ago and started reporting, and everybody in the system knew what the complication rates were, and boy, did they start coming down. So I think that's what we have to do right across the globe. We can't hide these things anymore. We have to be transparent. I mean, Rosie's story was horrific, and she's telling it. And we need to have patients out there telling their stories until these numbers are reported every day, and patients can see them. So now they can start to ask questions. Am I at risk for this? What are you going to do to prevent this happening? And become interactive in their care, instead of really sitting there quiet, intimidated by the physicians, the medical profession, who they're stressed. They don't know really what's going on with themselves, and they're just trusting everybody when they should be asking questions to make sure they're not making errors.
Thank you, Michael Ramsey, for that. I think all would agree about the need for transparency and shared information. And I do think there's an issue around here about leveling the information playing field. I think it is absurd that it's still in many places and contexts not easy for patients to see their own electronic health records, yet they are the common fact behind every healthcare encounter, and most of the clinicians they see only have half the information about them. So that to me is a big safety issue too. But I think we need to hear from Asmahan here, please, about how best to share learnings across different countries and cultures. And just an additional question, which is Michael Ramsey touched on, is that having a carer with you at an encounter with a health professional, do you think that not only writing things down but recording a consultation would be helpful for patients whose first language is not, you know, English, or in the country where they're seen? And in fact, that may go for all of us, because it's very hard to take in information when you see clinicians. What do you think on this, Asmahan, please?
To share learning across different countries and culture, we need to connect online. By using internet, sharing the information through websites, social media, and online meeting, we need to try WhatsApp, Telegram, or any platform that community already use. Thinking about video and pictures to share learning too, not just to prepare. Not just paper and leaflet, because, you know, sometimes people don't read the leaflet and or they don't understand even what's written on. Again, translate the important information to different languages. Like we have some leaflet translated to different languages. You know, people will find it very easy to read in their own language. And when we have opportunities to travel and exchange information, I think this is like to meet, and that will be very good to share the opportunities, and again, to support the former of partnership with community groups, who's often serve people from different countries and culture. This will help build strong relationship quickly in order to share learning. When we use simple method, we can easily share what we have learned with people from different places and background.
Thank you very much for that valuable viewpoint. We can do it. We can do it better. We can harness, you know, new media to do it. I've got an intriguing question here in the Q&A box, which is, if we move, and we are certainly in the UK and globally, to provide more healthcare, including acute hospital type care in community settings and in patients' own homes, you know, through hospital at home movements and virtual wards. Is this going to help patients to feel more engaged? Could it improve patient safety? It's certainly the message I got from the last World Congress on hospital at home was that the whole thing is pivotal on the patient's carers really understanding the situation and playing a massively important role in helping care for the patients, and it'll only work if those carers are really empowered to play their part. Do you see this as a sort of key move? Amanda Altman, can you give your views?
Yeah, I'm really interested. I don't think it's a solve, but it will definitely potentially highlight some inequity in many ways. In that, if you are in a home environment that has some level of privilege, including a caregiver that can provide support and understanding and has advanced health literacy, you're likely to benefit yet again. But if you aren't in one of those communities, or have in some disadvantage, then we're really going to have to work harder to provide that additional support. This isn't. We already see this in hospital, so it's going to be interesting to see how it plays out. And those who are even wanting to be in a home care environment versus being asked to be in a home care environment will be an additional aspect to consider. In Australia in particular, we have our issues surrounding rurality and regionality, and that impacting the quality of care that's being provided. And we've learnt some hard lessons about the benefits and pitfalls of using telemedicine in over COVID and much before this. So I think we have a lot of maturing to continue to do, and to not assume that technology can be a quick fix for any of these things when there are a multitude of human and social determinants of health that are really going to come into the foreground when we start doing this in more advanced care and community settings.
Yes. Would anyone else like to comment on the potential and pitfalls of more care in the community, whether it could make care safer or it'll just increase inequity between those who can do it well and those who are not in a situation where they can do it well? Yes, Michael Ramsey.
Yeah, I think one area it did work for us was when COVID was really bad, and we were having to almost close the hospital down and convert every bed into a ICU bed. We were able to keep a number of COVID patients at home who had the right setup at home, and we would monitor them remotely. We'd put little pulse oximeters on them, and we'd tell them when that O2 sat drops below 90, call us or come back in. And there's technology now that was set up so that they would trigger their cell phone plus our cell phones or the emergency room cell phone, director's cell phone, and let them know this patient's desatting at home, and that would bring them back in. And that way we were able to keep a large number of patients out of hospital, and so we could continue some regular important surgeries that needed to go on, transplants, things like that, despite a really big influx of patients with COVID. So it helped take the load off to a degree. So I think that is probably going to expand as technology gets better.
Yes, I think the trouble is that you know, we can have wonderful technologies, but the fact of the matter is, and this is touched on in a question in the Q&A box, it's around, you know, how can we really expect healthcare professionals who are stressed with a huge patient loads, burnt out, to respond better to the calls for care and support? I mean, I sort of listening to Martha Mills' mother talk about how often they articulated their concerns. They were empowered, they spoke up, but people just didn't seem capable of, didn't take them seriously. They were fobbed off, they were busy, they were, you know, whatever. How can we help the health professionals step up to the plate? I mean, when they're already sort of feel completely under the cosh. Jane O'Hara, do you have views about this?
I have lots of views. I think it's a really important point, and I think sometimes we can sort of other these conversations around patients and families and their role and all of that sort of thing, and talk about it in the absence of really thinking about how all of this stuff might sit within health services. And I think it would be unwise of us to not acknowledge that this is a really important part of it, that actually healthcare systems globally are incredibly challenged at the moment, and working under particularly difficult conditions, coming back from a pandemic in particular. And so it is a difficult environment to start to make change, significant change in these areas. I think one of the things that we have often talked about in our work over the last decade, really, where we've been trying to get staff to see the value and to be able to work with patients and families in a more partnership way, is to say that actually, although some of these things do take more time, or they might seem like they take more time, they actually take time back from other parts of the system. So for every 5 minutes you can spend with somebody as they're being discharged from hospital, that might mean that they take their medication correctly. That might mean that they understand a bit more about their condition, and so they know when to come back to healthcare services to represent to those services and escalate their care effectively. So I don't think any of us have any magic solutions, but I think perhaps one of the things is to say, it's kind of a stitch in time saves 9 kind of situation, that actually if we can invest more in these relationships, in these discussions between patients, families and staff, that we can actually then maybe support and free up time in other parts of the system.
Excellent. I think that's a very good wrap-up message. Time spent face-to-face with patient and families will reap its own rewards in terms of quality and safety of care down the line. Now, as I close this session, I wonder if I could just ask each of you in turn very quickly to answer in one sentence how to best to support the elevation of the patient's voice to improve patient safety. A take-home message. Amanda Ullman, please.
I think we need to create healthcare systems that are as good at listening as they are at talking.
Excellent. Michael Ramsey, a sentence.
Let's make sure there's always a patient on the board of the hospital.
Excellent, thank you. Asmahan.
The governing board of the hospital.
Yep. Asmahan Al-Nadawi,
yes.
Your message for.
Okay. Safety improved when we truly listen to the patient, families and carers.
Thank you. Jane O'Hara, I feel you've almost given us your sentence, but you can jump in with one more if you would like.
I think for a long time we've thought about healthcare as them and us, that there's systems and patients. I think we need to just think about it as us collectively creating safety of healthcare.
Thank you very much. That's very good to hear from you. I'll hand over now back to Bryony.
Excellent. Thank you, Tessa, for chairing that session. And wow, what a fantastic discussion that was. And thank you to everyone who put questions in the Q&A as well. Some really great questions. I hope you all enjoyed that session as much as I did. Thank you too to Jane, Amanda, Asmahan and Michael for sharing your views. We now come to our final plenary session of the day, which will be from the MP, Maria Coalfield. She was appointed Parliamentary Under Secretary of State at the Department of Health and Social Care and the Parliamentary Under Secretary of State and Minister of Women for the Equality Hub in 2022. She was previously Minister of State for Health and Social Care between 2022, between mid and the end of 2022. So we're going to hand over now to hear from Maria. Thank you.
Good morning, good afternoon and good evening to everyone joining us from around the world. I'm delighted to be speaking to you all ahead of World Patient Safety Day on the 17th of September. And I would like to begin by paying tribute to the Chancellor, Jeremy Hunt. It was his energy and vision as Health Secretary that led to World Patient Safety Day 4 years ago, putting one of the most important issues facing governments and healthcare providers around the world firmly on the global calendar. I'd also like to thank Lord Darzi for being such a tireless advocate for patient safety and for hosting us today. For thousands of years, medicine has operated on a simple principle: first do no harm. No patient should be harmed when they seek care. It is a principle that I have taken forward in my own career as a nurse, working in our National Health Service, and now as the Minister responsible for patient safety. Patient safety is the golden thread that runs through everything nurses, doctors, and all those that dedicate their lives to caring for others do. This year's theme for World Patient Safety Day is dedicated to engaging patients for patient safety. I welcome this focus on patient centricity. We simply must put patients at the heart of our health systems, involving patients, listening to their voices and acting on their concerns. Today, I want to give you 4 examples of how we are advancing patient safety across our NHS. Firstly, shortly before the pandemic, the NHS published their first ever patient safety strategy under the leadership of our National Director of Patient Safety, Dr. Aidan Fowler. The strategy has meant that the NHS organisations must have a dedicated patient safety specialist, as well as support all staff to receive robust patient safety training and use their data to quickly recognise risk to patient safety. The strategy has also introduced patient safety partners to NHS organisations up and down the country. Patient safety partners are patients, family members and carers with personal experience. It's important that we make use of this valuable resource. The NHS estimates that the patient safety strategy is already saving around 500 lives a year. This is a great start, but of course there's more to be done. Second, in 2021, the NHS introduced medical examiners to independently look into deaths that haven't been investigated by a coroner. All deaths which occur in a hospital setting and a significant and growing proportion of deaths in the community are now being scrutinised by appointed medical examiners. These senior doctors also reach out to bereaved families and give them the chance to raise concerns, to ensure that every possible lesson is learned when standards fall short. And from April, it will become a legal requirement for medical examiners to examine all deaths not reviewed by a coroner in all medical settings, including in primary care. Third, in maternity care, NHS England launched the Maternity Safety Support Programme to ensure underperforming trusts receive assistance before serious issues arise. And in 2020, NHS England's Getting It Right First Time programme expanded to cover neonatal services. They looked at some of England's neonatal services using state-of-the-art data and gave trusts targeted improvement plans to work towards. Finally, I want to say something about whistleblowers. Whistleblowing is key to building both transparency and accountability in our health service. We have a debt of gratitude to whistleblowers who speak up when they see wrongdoing, and it is vital for leaders to create the conditions where whistleblowers feel they can openly voice concerns and be supported. That's why last year, NHS England strengthened national freedom to speak up policy and is expecting all NHS providers to adopt the updated policy by January at the latest. We want to make sure everyone working in the NHS feels safe and confident to raise any concerns they have. At the same time, the government appointed Dr. Henrietta Hughes as our first ever Patient Safety Commissioner. I hope you all enjoyed hearing from her earlier. Dr. Hughes is a champion for patients in relation to the safety of medicines and medical devices, and in doing so, promoting good practice in listening to patients throughout the health system. In just over a year in post, Dr. Hughes has brought a wealth of experience from having led the National Guardian's Office. She understands better than any the need to listen to patients, support whistleblowers and promote first-class transparency in the NHS. We must never forget that it was thanks to the efforts of whistleblowers that the horrific crimes of Lucy Letby were exposed. I recently met with the victims' families. They have suffered more than I can begin to imagine. Their wishes and views are vital as we shape the response to the events which took place at the Countess of Chester Hospital. That is why, following consultation with the families, the government took the decision to move to a statutory inquiry with the power to compel witnesses under oath. We have a duty to provide the families with the answers they deserve and make sure lessons are learned. I want patients and their families to have total confidence in the care that they receive and for hospital leaders to embed a safety of culture across their organisations. This is a challenge not just for our health system, but every health system across the world. With your help, we shall rise to the occasion and make sure that patient safety is at the forefront everywhere. Thank you.
Thank you, Maria, for that really inspiring talk, and I think a great way to be bringing our session today to an end. So just in the last couple of moments, just to end with a few thoughts and a few practicalities. First of all, thank you to all of our speakers and our panelists for making this such an inspiring event. Thank you to all of you who've listened, participated, asked questions and watched the event. We really hope it has inspired you to take action in your own practice. If you're a healthcare professional, a healthcare member of staff or a researcher, I hope it has inspired you to think how you can involve patients and families in all that you do. If you're a patient or a member of the public, I hope you feel that you can let us know how we can help you to let your voices be better heard. In a moment, we're going to be sharing the second canvas from Chris, our illustrator, and I know the fantastic discussion that we had in the panel just now has certainly kept him busy with creating lots of thoughts, which we'll be able to look at in a moment. And finally, what will happen next? A recording of this event will be made available on the Institute for Global Health Innovation YouTube channel so that you can watch this again afterwards, and importantly share it with colleagues who were unable to attend live today. So this will go out early next week as part of an electronic goodie bag to everyone who registered for this session, and this will also include resources and more information about patient engagement initiatives. That'll include a brief survey, a very, very brief one, I promise, at which we'll be asking for some feedback from you who have attended today. And we'll also be providing answers to some of the questions that were raised in the Q&A that we didn't have time to address today. So please do look out for that link as it comes out to you early next week. But finally, what I would encourage us all to do is to keep this conversation going. What we've had opportunity to do today is to hear from patient stories, from a wide range of perspectives and some really inspiring thoughts. Please do keep this conversation going so that we can truly elevate the voice of patients and families in all that we do. Thank you for joining us.